Good afternoon, everyone. Thank you for attending our symposium today. This is the second session in our Innovative Care series. During the first session, we covered statewide innovative care initiatives that are currently underway, how quality measurement supports innovation, and innovative models for managing patient populations. Today, we'll be expanding on team-based care, discussing the Maryland model, team-based approaches to facilitate improved care outcomes, and population health models and team-based care. So first, just a couple of informational things and the disclosures. So can we go to the next slide? So we can go. So these are the disclosures for today's activity, and just a reminder that it is being recorded. So these are required disclosures for continuing medical education credits. So I'm not going to read these out loud, but I do want to point out that there were no financial disclosures from any of the presenters today. So with that, is Colleen George on the call?
I am.
Hi, Colleen. Welcome. So I would like to invite Colleen to say a few words. MedChi is sponsoring the continuing medical education credits for this session today. Thank you, Colleen.
Thanks, Melanie. You know, you've kind of taken what I wanted to say. I just wanted to welcome everyone to this webinar. I think this series has proven to be so excellent, and the speakers that are giving their time are amazing, and I think you'll all learn so much from this. MedChi is more than happy to sponsor this webinar for CME credit. We believe strongly in the relationship between MedChi and the state, MHCC and Department of Health, and all the entities that keep us going and keep us honest. So with that, just enjoy the webinar. I think you're all going to get a great deal out of it. So thanks, Melanie.
Thank you, Colleen. So at this time, I would like to invite Tequila Terry to tell us more about the Maryland model. I'll hand it over to you, Tequila.
Thanks, Melanie. Well, good afternoon, everyone. I'm delighted to be here with you today. My name is Tequila Terry, and I am with the Health Services Cost Review Commission. And it is my absolute pleasure to be with you today to talk a little bit about the unique model that we have here in the state of Maryland, and really how it supports and encourages innovation across the healthcare spectrum. So if we can go to the next slide. Many of you may have heard of our unique system referred to as the Maryland Health Model, or the Maryland Model, or the Total Cost of Care Model. And really, those are all different names for this unique system that we have in the state of Maryland that is made up of two key components. On the lower right box, the all-payer hospital rate setting system, which we've had in the state of Maryland since the 1970s. It gives our agency the authority to actually set the rates for for services that are delivered by hospitals. And then that is complemented by a series of agreements or contracts that we have as a state with the Centers for Medicare and Medicaid Services. And these agreements really are designed to encourage healthcare system transformation, innovation, and ultimately new models of care that improve outcomes, address disparities, and reduce the cost of care. And so we've got two contracts that we have had over the past several years. The most current contract is called the Total Cost of Care Model. And so as a state, we receive a number of benefits as a result of this system. I won't read this whole list to you, but it certainly supports a number of healthcare investments and infrastructure around the state. And notably, because there is this key goal of fostering healthcare transformation, it really encourages innovation across the healthcare spectrum. So I'm going to talk a little bit more about the system, just so that you have some context for the next couple of presentations that you're going to hear today. Next slide. So historically, again, we as a state have had these agreements with the federal government that really focus on this idea of fostering innovation and encouraging transformation. The first agreement that we had with the federal government was called the all-payer model. It ran from 2014 to 2018, and it was sort of narrowly focused on this idea of what can hospitals do to transform delivery. How do we generate savings and bend the cost curve by focusing on hospitals? How do we improve quality by focusing on hospitals? But if you fast forward now to our current agreement with the federal government, it's called the total cost of care model, and it will run from 2019 to 2028. It really is focused on this broader system-wide impact that can be made, and really focused on broad savings across both hospital and non-hospital providers and the types of services that they delivered. And very specifically, it is focused on improving not just hospital quality, but population health. And so that really aligns perfectly with our topic for today, where you will hear about some really innovative approaches to improving health outcomes, to coordinating care. And this is really central to the concept of this model. Next slide. One of the things that we will have to think about as we move forward in our agreement with the federal government is that there are a number of strategies that we as a state will need to implement in order to be successful. So certainly we want innovative strategies that foster accountability and really create the opportunity for providers to be responsible for health outcomes of their patient panels. We want to make sure that the financial incentives are aligned so that everyone is rowing in the same direction and really are focusing on common goals. We want to transform care, very specifically coordinating care across, hospital and non-hospital settings so that people really do get the best outcomes, and we simultaneously constrain costs. And then finally, we want to really encourage statewide coordination and address really the most prevalent chronic conditions that we have in the state of Maryland. Next slide. To that end, one of the key components of the total cost of care model is what we call the statewide integrated health improvement strategy, or SIHIS. And what this does is it focuses on 3 key domains that we as a state will be targeting over the coming 10 years to really focus on opportunities to improve. So certainly in the hospital quality space, really enhancing our focus on avoidable admissions and improving readmission rates by addressing disparities in the hospitals, but then looking outside of the hospitals across the care spectrum to increase value-based care models and improve care coordination. And then finally, focusing on total population health, targeting those very prevalent chronic conditions that we as a state know we need to address and that people are really grappling with across the state. So as you hear today's conversation, really keeping sort of this strategy, this statewide health improvement strategy in mind is important. Next slide. And then lastly, just want to underscore that as a state, we are going to be working hard in the coming years to demonstrate success of the total cost of care model. And that means several areas of focus. So certainly continuing to make sure that the hospitals have high quality and that we are really focused on bending the cost curve by really achieving cost savings goals. But importantly, and really directly related to today's subject, focusing on healthcare system transformation and how we can ultimately improve population health by really supporting innovative care models that exist around the state. And so I'm going to stop there And I am going to turn it over to my colleague, Siobhan Kirksey, who is going to talk really about team-based care approaches to facilitate improved health outcomes. So I'll turn it to you, Siobhan.
Thank you so much, Tequila. Good afternoon, everyone. My name is Siobhan Kirksey. I am the Senior Program Manager at Privia Health, where I focus specifically on the Maryland Primary Care Program. I have been providing team-based care over the past 10 years to several different organizations, and my current organization is Privia Health. So today we're just going to focus a little bit more on the details, and hopefully you will walk away with some approaches that you can apply to your practices. Next slide. So there are 3 key areas of focus that we are going to discuss this afternoon. So 1 is, why is team-based care important? 2, the integration of team-based care. And 3, reporting to support team-based care and how to improve health outcomes. Next slide. So the first thing I'm quite sure that many of us ask ourselves, why is team-based care important? And I'd like to highlight just recently what happened when it came to the pandemic, and many of us trying to determine the best way to still continue to provide quality care to patients. And usually when you have team-based care already incorporated in some aspect, it helps to make that transition when we have to pivot to healthcare crises easy. So we're going to take a look at some of the important steps together. Next slide. So what is team-based care? The Institutes of Medicine defines team-based care as the provision of health services to individuals, families, and/or communities by at least 2 healthcare providers who work collaboratively with patients and their caregivers to the extent preferred by each patient, with the goal to accomplish shared goals within and across the settings to achieve coordinated high-quality care. So I'm sure many of us look at this definition and think to ourselves, of course, that sounds easy enough. And many of us think that we are already doing this. And so the challenge that I ask is, are your team members in your office also aware that we're practicing team-based care? Does everyone know their roles to support? And those are some of the things that we'll take a closer look at together as we go through the slides. Next slide. So the need for team-based care. The concept of team-based care is not new to many of us. If you've worked in a hospital setting or a large medical organization, you've seen through the years that there is an improvement in patient outcomes when a team works together. As primary care in the United States evolves from a volume-driven to a value-based reimbursement system, care delivery models for community-based practices must also evolve to ensure continuity of care. The patient-centered medical home was originally described by the American Academy of Pediatrics and was designed to help achieve the triple aim of improving health outcomes, improving patient experience, and controlling costs. Certain elements of the patients in a medical home, such as the team-based care, have improved outcomes, including quality care and provider satisfaction. And that's what we want to take a closer look at today. The goal is to determine how this works best for a smaller independent practice and anchoring the needed support to create success. Next slide, please. Provider burnout. Many of us during the pandemic know exactly what this is, and we see it not just amongst our providers, but also amongst the staff that's working together with us. So when I took a closer look at some of the studies, factors contributing to burnout and dissatisfaction include use of electronic health records, increased needs to see more complex patients, and change fatigue. One study found that physicians spend approximately 27% of their time providing direct face-to-face care to patients, and more than half of their time on the EHR, or specifically desk work. So when we're looking at the electronic health records, there is always this constant need for change that's shifting from value-based quality care needs, a change to risk adjustment, and then also hospital discharges. Patients are living longer. With longer life comes complex medical problems. And providers are focused on a triple aim to make sure that there is a focus on population health that enhances patient experience and also reduces cost. Next slide. So this is a study from 2019. which focused specifically, and it was performed by the National Academy of Medicine. And it was a study to focus specifically on burnout as an emotional exhaustion, detachment, or low sense of personal accomplishment. The study concluded that current understanding suggests that burnout is a growing public health concern among all types of clinicians, and that the problem has been growing for years, leading to an alarming rate of burnout caused by high stress, high demands, high patient case loads, long hours, and lack of resources. The American Academy of Medicine estimates that 35 to 40% of practicing physicians and nurses experience symptoms of burnout. The rate was even higher at 45 to 60% among medical students. In lieu of the pandemic, burnout is a high among all healthcare professionals, and change management is at an all-time high due to COVID as well as other factors. Next slide. So can team-based care actually help? Team-based care model can improve the following. They can increase visit volume and patient access, can improve overall clinical quality, and can also reduce provider burnout in half. Team-based care allows each member of the healthcare team to function at the top of his or her license, thereby improving efficiency of the patient care and ultimately the well-being and engagement of all members of the team. Team-based care can be led by a physician, an advanced practice provider, or an office manager that provides various elements of a visit's care together, each practicing at the full extent of their training. This model really engages a greater number of staff and allows the provider the time to listen to patients, carefully consider differential diagnosis and treatment plans, and cultivate meaningful relationships with patients. Also, it provides the team members the knowledge and background of patients, histories, treatment plans, thereby better equipping them to respond to patient questions and requests between visits. Ultimately, all members of the team feel more engaged in their important role for caring for the patient, and we're all doing it together. So now we're going to take a look at integration. I am sure the first part of the slides gave a lot of things to think about, but the most important part is, if you're considering this, is how to integrate this into the practice to facilitate the change that you're looking for and the outcomes. Next slide. Change management, to get started, is to bring pretty much your team that you have in place together. And so that might be nurses, medical assistants, physicians, if you have an office administrator or manager, as well as IT, who can either be led by a physician or an office manager who has enough authority within the practice or organization to empower the process. The change team's task will be to design the team-based care model that will best serve your patients and your office population. Consider expanding the roles of current care team members and add any new roles to create the ideal model for your practice. For example, your practice model may call for a behavioral health specialist, maybe a health coach, care manager, care coordinator, or a pharmacist to work together for you. Leave that option open. Someone just said that in the comments regarding the pharmacist. Yes, definitely consider a pharmacist. Pharmacists spend a great deal of time helping with med reconciliation. With the Maryland Primary Care Program that our team is a part of, we definitely employed a pharmacist, but we did take time to work together with one. So many of you guys may not realize it, and I'll get to and answer any additional questions, but some of you may be already working with pharmacists. My relationship with the pharmacist started when we worked with Novo Nordisk, and we were able to build on that relationship and do a meaningful transition to have a pharmacist on our team. So being able to help with medication costs, medication adherence, even instructions is a great asset to your team when you're providing team-based care. Next slide. So the design. So these are just some fundamentals you want to consider and think about. So are you able to do pre-visit planning or a daily huddle? Are you able to expand rooming and discharges? And we're going to discuss a little bit more in detail what I mean by that. Is there a way where we can do team documentation, medication management and reconciliation, either by a nurse if you have one in your office, or if you're working in partnership and collaboration with a physician? Your electronic health record in-basket management, reporting dashboards, and our favorite, the Patient Family Advisory Council. So your patient family advisory council is able to be and provide, I should say, they are able to provide a significant help to when you want to transform your practice into team-based care. They often offer feedback, but maybe we may not have been aware of, such as if your office doesn't have a way to do online scheduling and you have a high population that would love to be able to do online scheduling and online check-in, that takes some of those fundamental processes off of your front desk staff and shift them to the responsibility of your patients to be able to help support. But PFAC meetings are very informative and can provide a lot of help when you're designing a team-based care. This workflow that you're going to decide together needs to fit your care center and improve goals. Think outside the box when designing your dream team or ideal practice. The sky is the limit because you're just in your beginning phases of determining what team-based care is going to look like and what goals you want to accomplish for your practice. Remember that this is your chance to create your ideal future. If you have access to a lean expert or maybe an operations consultant, work collaboratively to identify opportunities for greater efficiency in the current and newly designed processes. And just to expand on the topic of expanding room and discharges, this specifically means allowing others to help support your intake processes and discharge processes. In many of the offices, the doctors sometimes do their own vitals, walk a patient back, and do discharge planning. When you expand that process, you're allowing for your MA to really complete your intake of that patient, getting all of the necessary information that's needed for the visit, and also being able to tap into team documentation where they're able to document this information directly into the chart. From there, once a provider is finished seeing the patient, then either an MA or maybe you have a nurse that works with you can come in, go over discharge planning, explain any questions or concerns that they have, and make sure that everything is reviewed. In some offices, that nurse that comes in is also able to help with scheduling appointments for future visits. Next slide. So your pilot team. So this is important setup to your success. When aligning the pilot team to be the ideal team model, you're developing change teams, keep in mind the following. You want to make sure that there is role flexibility, which is going to be a part of your practice culture now. Practice culture will change from practice-centric to patient-centric. Make time to learn new responsibilities. This prevents resistance to change. And eliminate unnecessary activities and waste. So this is a great opportunity when you're developing your pilot team to eliminate redundancies in workflow. So after the change team has agreed upon the basic team-based workflows, you can assemble smaller teams that will pilot the model. This pilot may consist of maybe a physician or a pod leader or a nurse or an MA specifically. Members of the pilot team should be the trailblazers and provide good communication, willing to put in extra effort to prepare for the transition and continuing to develop the model once it's underway. Prepare your pilot team by informing them that team-based care implementation will be a gradual process. In some offices, folks are really, really excited about change, and in other offices, change is almost cringeworthy. So you want to make sure that you take the opportunity to give them time and grace and make sure that they understand that every day is not going to be perfect. So they need to be patient with themselves. Change can take several months, and there may be times where the team feels like they are really gelling in this new system. And you want to make sure that you're celebrating those opportunities and those times together. Next slide. Consider external partnerships. So many of us work with many of our teams in the communities, and they could be a big help when it comes to team-based care. So examples of external partnerships can be a hospital transition of care team, community pharmacists, if you can't employ a pharmacist, behavioral health specialists, or local health departments. Use of any of these partnerships can help strengthen your team-based approach. Hospital transition care teams provide better coordination of transitions of care beyond a discharge notification that many of us receive from CRIS. If you want to improve medication adherence, support from a pharmacist is the best approach. Targeting a few patients monthly with a pharmacist strengthens your relationship building and partnership while improving patient outcomes. And behavioral health has always been a challenge for many of our patients. So consider a collaborative approach with a behavioral health specialist allows a patients to have needed access to care while providing in-office support. And that's having a collaborative agreement. So a collaborative agreement allows everyone to win. With us at Privia Health, we have a collaborative agreement in place with Mindula Health, which allows for us to provide our patients that may not always have access to behavioral health specialists a partnership in a way to gel and work together. Next slide. Now we're going to take a little bit of a look at reporting. So we've done all of the hard work, we've put the team together and we're gelling, but is the team actually working together to improve the health outcomes that we'd like to see? So let's take a look at a few options that you can have to help support this new team that you've created. First up is our risk stratification reports. Risk stratification uses a mix of objective and subjective data to assign risk levels to patients. Practices can systematically use patient risk levels to make care management decisions, such as providing greater access and resources to patients in higher risk levels. Risk stratification helps practices to better focus on their sickest patients, reduce costs, and improve care. It may take some time, but it's important to incorporate the care team's perception of risk. The practice must be committed to making a team-based approach that values the input of both non-physicians and physicians, and a commitment to developing and adhering to structured workflows. This may be a new way of thinking for some practices, and not all are ready for it. Smaller practices typically can accommodate changes like these more nimbly than larger practices because smaller practices may have fewer administrative burdens when it comes to creating a risk stratification. Some of the concepts to think about when you're looking at your risk stratification report will be just the simplest of just determining how many tiers you want to look at. As you see in this example here, there's 4, but some risk stratification reports go into more detail than just having 4 risk categories. Also, you get to determine to think about if you want to include medications, which medications. Is age a factor that matters to your risk stratification? Really make sure you take the time to sit down together to discuss as a team as you develop your risk stratification reports. Next slide. Huddle reports are quick snapshots of pertinent information to help your team plan your day. This goal of a huddle report is to allow for proactive care of patients versus being reactive. So the best way to develop huddle reports is one, to see if it's available in your EHR already. If it's not, you can work with your data team to determine what you want your huddle report to look like. What is the quick snapshot of information that you think would be helpful to you and your staff to prep and prepare for the day? And this here just focuses on a couple of things. You can see very quickly at a high level the last time the person was seen, whether or not if they had any ED or inpatient discharges, if they've had any cancellations. You get to see really quickly their last couple of blood pressures as well as their last BMI, which also tells you if there's been a weight gain or weight increase. And then if there's any measures that are still open. On this one, you can see that this particular patient would still need a screening to complete a screening for depression and follow-up. But sometimes this has information on it for our Medicare patients, like they may need an annual wellness visit, and they may be coming into the office for a sick visit. It's a great way to just capitalize on every moment that you have with the patient, and your team is working on those efforts together. Next slide. Next is a quality measures report or dashboard. These are some of the quality measures that I think all of us focus on when it comes to taking care and managing patient care. So when starting to implement a team, you want to make sure that everyone understands what the goals are when it comes to patient care and what you're specifically focusing on when it comes to quality. If team-based care is going to be a new concept, you may not be able to tackle all of these at once. Maybe you've looked at a report and determined that your diabetic population is having a high level of ER and inpatient visits, and you really want to focus on diabetic management first because that will decrease ER visits and inpatient visits with that population. Just make sure that you have time to review your data, understand that everyone needs to know where the support lies and what we're focusing on. And for some of these, the data will change with the time. So for example, flu season doesn't open until September. So having information on how you did in the past, meaning the year before, and being able to focus your efforts on what's needed for future patient population is a great way to look at comparison quality data as well. Next slide. So this is a sample of a dashboard specifically targeting and looking at diabetic and hypertension quality care measures. This is a float over time. So it'll let you see where you started at the beginning of the year, if you pull it at just the right time, which is usually after you started to see patients in January, and then being able to give an overall comparison of the change that's taking place. The goal is to make sure that you are improving health outcomes for your patients, as well as being able to see that performance over time. Together, you and your providers and your staff able to see change on time helps solidify the fact that your team-based approach to care is working, and you're able to really harness in on what else needs to happen throughout this measure, or being able to start incorporating additional quality measures now if you have one set of goals and program structures on task to help support your patient population. Next slide. This last one is sometimes my favorite. So this one is a management performance dashboard that will allow you, in this model that I have shown and featured here for you, it just allows you really quickly to compare the different regions as Privy as a large group. But in smaller practices, you can compare providers in terms of how you're performing versus benchmarks that the market has set for us to perform well in different areas. So this one allows you to see change over time as well, but more so drilled down to a provider level. And at that same time, you're able to see areas where we still need to continue working. And that's what I like about this report the most, that you're able to see really quickly your areas of improvement. And most reports that are built like this have a patient list. So you and your team working together can identify those patients that still continue to need additional support to get better health outcomes. So just a few takeaways to remember. There's 3 things that I want you to remember. Next slide for me. Communication is important to developing a team-based model. And 2, collaboration and partnership are always the keys for the successfulness of your team-based care approach. You need to make sure that you're going to be patient, nurture your new vision, and watch how it changes how you deliver care to your patients. Thank you. And with that, I'm going to turn it over to Dr. Ashley Kinder. I might have butchered your last name.
Kinder, it's good.
There we go. Thanks so much.
Thank you, and thank you for that wonderful talk. I'm Ashley Kinder. I'm a MedPeds primary care physician with Ascension St. Agnes, and I'm also the medical director for our population health infrastructure, which we call the Health Institute. I too work closely with our MDPCP program and our CTO, and so you'll hear some overlap in the talk today, but I'm going to focus a little bit more, rather than at the work at the office level, our work at the system level and how we can work together across systems to connect the innovations that we're seeing throughout our state. Next slide, please. So objectives for this talk. First, I'd like to review the barriers to effective care coordination across our continuum, which many of you will be all too familiar with. Secondly, talk about strategies at a system level to promote both patient-centered and team-based care delivery. And lastly, highlight the role that strategic partnerships play in being successful in population health management. Next slide, please. So I want to lead with a patient case of a theoretical patient, just to highlight how fragmented our systems are. And we all know this. It's something that frustrates us as providers, as caregivers, as patients ourselves, as we move through the continuum of care. And I think no state or system is unique in facing these barriers for our patients. But I want you to first imagine a patient who was admitted from home to the hospital with a COPD exacerbation. This patient is now discharged on multiple new inhalers that have costly copays. They're asked to take a nebulizer medication that needs a separate form completed. And one of the discharge medications that they are to take now requires a prior authorization. So hopefully she's able to see her primary care provider for a transition of care visit. And perhaps that doctor is in the same network with the hospital where she was admitted. We all know that isn't always the case. But for this example, let's assume she's able to make that visit, have her medication reconciliation, perhaps see a nurse educator regarding her COPD. Well, unfortunately, she ends up retaining fluid after her steroids for her COPD and is readmitted, but this time to another hospital across town with a different EMR, a different care team, and now she has a heart failure. This team can't see everything that happened in her doctor's office, but hopefully is using the state health information exchange to get some of that information. She's too ill to leave the hospital, and so is sent to a subacute rehab facility, again with new medications, another EMR, and new outpatient follow-up plans from this discharge. She forgot her meds over the holiday weekend and becomes short of breath, calls 911, and is in yet another emergency room with a different EMR when she needs care for her, again. She's referred to a different cardiologist, again, not in the first system, in the second system. And now this patient probably has 6 or 7 different discharge documents with medication reconciliations to manage at home. So why am I spending so much time on a slide that's telling you something you probably already know? Next slide. I've added stars to tell you all the times where she probably received outreach from someone with one of our care teams trying to navigate her care. And so while the systems are very fragmented, unfortunately, so is much of our navigation at this time. So many of these institutions will have wonderful and robust transitional care teams, each designed either to navigate perhaps inpatient discharges, patients who might be deemed high risk for readmission, or disease-specific programs around conditions like COPD, heart failure, or diabetes. In addition, the primary care, whether through the MD-PCP program or other models, may have an ambulatory care management that is trying to outreach to this individual. And our payers may also have mechanisms that they're targeting patients who've recently been hospitalized. Some specialists are moving to more ambulatory care management models or disease-specific care navigation that also are outreaching to patients like those shown here. Even in our post-acute settings and ERs, there's more innovation happening. And this is all wonderful innovation, but it still remains in many ways fragmented. Meanwhile, this patient is at the center, trying to understand what she needs to do to be successful in her healthcare. And she may have a pharmacy or home care, other specialists involved that are not shown here. So we need to remember at the core as we build out our teams and attempting to make our systems more straightforward for our patients, we can actually add to the confusion if we aren't coordinating the coordination itself. Next slide. So the next barrier is much of the work that I believe we need to do in this space is really outside of health systems. Social determinants of health are a significant driver of how well this patient will be able to navigate this fragmented system and a predictor of our clinical outcomes. There's a large body of literature regarding the impact that social determinants play on our patients' outcomes, things like their financial strain, transportation, social supports, and the built environment like pollution and food access. So while we consider what interventions we need to address those problems, we even further fragment that slide that I showed you earlier. Despite health systems moving and having more internal programming to support social determinants of health, many of these will really require collaboration with community-based organizations, health departments, and regulatory agencies to truly begin to move the needle. This has only become more challenging in the COVID pandemic, with the landscape for existing resources changing significantly and disparities deepening. There is an important note to be made that some of these are modifiable at the individual level. Others really require more of a systems approach to begin to address. And so as we're working in our team-based care to look at how we impact our patients, we need to consider both of those lenses. Next slide. And a third barrier is that many of us are really still learning to work in multidisciplinary teams. Most of us didn't train in the multidisciplinary team in the ambulatory setting, at least of today. We perhaps had some exposure to working with other disciplines, perhaps a nurse or social worker. But as we bring pharmacists into our team, behavioral health specialists, community health workers, peer recovery coaches, and other individuals with shared lived experiences, this may all be new to our teams. And as we know, working in new teams has new barriers. One study divided these really into kind of individual and inter-individual or team-based barriers, as well as the organizational and system challenges we face. So for example, an individual might not really understand their role in the team, so they're not able to be as effective because they're not sure what they're supposed to be doing for the patient. Teams themselves might struggle with communication strategies, interpersonal dynamics, and defining those roles as well. At system levels, we're facing workplace shortages, financial considerations, and often insufficient data and analytics to really give us information about short-term returns on investment, which we often need for funding. Training and standards of work may be lacking, and sometimes even physical space to house a multidisciplinary team is a challenge in some of the areas we work. It's really important to engage clinicians, and by that I mean clinicians broadly, not just physicians and APPs in this team-based work and helping us to learn in these new roles. And arguably some of the best evidence for learning to do this is really learning by doing. But that's very difficult to do in an environment where we are all learning and growing so many new things all together. We are very thankful for the support systems we have in our state that allow us the ability to create this infrastructure. And the more we do it, the more I am confident that we will start to overcome these barriers. But as you heard in our last talk, many of us are in different places in that change continuum. And it's very important to remember that as we build these teams, that this is still a learning process as we grow. Next slide. So how do we promote this team-based care at a system level? So one of the first things that we realized in our own organization was that we needed to acknowledge our silos and really make structural change. I have to say this was incremental, and we're still adjusting our structure as we grow and as the healthcare landscape changes. For us, we brought our programs under a single shared leadership that we refer to as the Health Institute. At first, we began with inpatient, outpatient, and emergency medicine care management into one continuum. We brought in community health programs, which included things like diabetes education, diabetes prevention, and food intervention. And then we later added our ambulatory behavioral health and substance use disorder programming. In addition, we are excited to now add some of our post-acute programming and initiatives under the structure, acknowledging how important post-acute is in the role of addressing care across the continuum. Structural change is challenging, and it sometimes can feel like you're fighting an uphill battle with all these moves. And so each organization has to look and decide what is the most effective structure, how to align incentives to work across the continuum. For us, we found that there were components that we could tie in through a non-direct reporting relationship. So our ambulatory quality and value-based care work does sit under a separate reporting structure, but is melded together through my role as the medical director in population health. We know it's really important that quality, value-based care, and population health all align, and Ascension is doing so nationally as well to try to make sure that we're bringing our work together, not creating duplicative processes, and really looking at best practices across our care settings. Next slide. So the next lesson or thing that I would suggest is sometimes you need to navigate the navigation. We call this air traffic control in our organization. So the slide with all that calls, I truly tell you, this is not an exaggeration. We see this all the time. And we can't fully control all the calls and contacts that our patients receive from external organizations trying to help manage their care. It's all well-meaning, and it's probably all very excellent care. But we do need to make sure that we decide who's the air traffic controller and that we don't overwhelm patients so they disengage. The first thing is when we navigate that navigation, really how we identify patients and how we triage who should be managing their care. That's easiest to start with in your own organization, but there are some tools that we can do that externally as well. When we generate our own outreach list, we first needed to figure out what team should take precedence, who should call them and be that first point of contact. In our case example, I might suggest that if that patient has a robust relationship with their primary care office, that really primary care is probably the best to do that outreach. But what if they are well established at a heart failure clinic that knows them very well and they have great relationships there? You may find that that initial outreach is best from that clinic where the patient is already engaged. You also need to look at the patient's needs. So in the example I presented where she is very well connected to a primary care and perhaps has fewer social determinants barriers, that may be the best resource to outreach. However, we have patients who don't really connect with primary care. Perhaps they no-show frequently or aren't able to establish due to access issues. Perhaps they're not in stable housing or they don't have adequate access to a phone. Working with a hospital-based transitional care team that can meet them at bedside and engage them in person may be a much more effective intervention than a telephonic intervention post-discharge. So the individuals in each group, when we look at lists or when we identify our patients, there needs to be a stratification that really looks at engagement as well. Providers are great assets in helping us to engage patients, and we really encourage our providers to talk about our programs and talk about how our nurses or social workers are part of their team. I have to say that for them too, they need air traffic control, and it's very hard to understand who is eligible for which program. Perhaps there are limitations by zip code or income or all of these other requirements. So making it easy for providers really helps them to be allies in your referrals to team-based care. We have a system where they make a referral to the need for navigation, and we handle subsequently what that navigation will be, and have found that to be much more effective than kind of asking them to determine what program the patient belongs in initially. Also, if things change, right, or a patient perhaps was eligible for a program and is no longer, and the provider refers them to that, it actually can hurt not only patient engagement, but provider engagement, because they think that the patient has access to a resource that perhaps has shifted or changed its funding source. And lastly, I just want to highlight again that issue of determining a hierarchy of what you try first, but also what you try next. So if one team has tried multiple times to engage a patient unsuccessfully in a program, you really do want to try something different. And while that sounds very intuitive, it's not always obvious in the systems that we design that outreach to our patients. When you're looking at who's going to do your air traffic control for your organization or your office, you really want someone who can think critically about this and really ask, what does the patient need? What have we tried? What hasn't worked? Sometimes you may start small, and really sometimes we have to triage based on resource availability. But as we develop new community partnerships, new programs, new referral sources, this can become quite complex work. And so I do want to highlight really the value of having someone in your organization who can help triage your referrals. Next slide. And so the third area kind of I want to highlight in a solution to some of the barriers we see is really both leveraging your IT systems as a communication tool, but not letting that supplant the importance of relationships. We all live in our EMRs these days and recognize that many of them do have systems to help us communicate more effectively, or even secure messaging tools or apps that are outside of your EMR. These are really valuable, and I think they're probably underutilized by a lot of teams, and something to think about how you create standards of work that help you to have predictable communication patterns. I also want to highlight the crisp care alerts, which are a wonderful tool for us to communicate across systems and across teams. Hopefully many of you are already familiar with these tools, but they really are a great mechanism by which we can air traffic control. I think of the IT communications and the electronic communications as a foundation, but particularly for very complex patients, relationships are really key. And not only relationships between the patient and the providers, but with the team, so that the patient knows that that team is really working together. For us, we use primary care huddles as a tool to really help engage care teams in discussing high-risk patients, how we'll outreach, what's going on with the care plan. Hopefully many of you are using these as well. We also have a multidisciplinary rounds that include both ambulatory and transitional or inpatient-based teams that bring together specialty medical directors, care management leadership, and our frontline caregivers to really talk about challenging cases. The benefit of this is not only that you can solve or troubleshoot a particular case, but you also expand that learning to the entire care team so they can see how we think through difficult cases, how we work together and triage different resource needs. Next slide. So I briefly just want to highlight partnerships and engagement, because the core and foundation of this work is really being able to engage that care team and also engage those beyond our four walls. So I would encourage everyone to ask, who in my community is doing this work and what does my population need? You can use information such as public health data as a very valuable tool, but I also encourage you, as you heard in the last slide, ask your patients and families, use those PFACs, ask them what they need, they will tell you. Work with community members and leaders who are active in your system. And above all, I encourage everyone to screen for social determinants of health as a routine practice in primary care. I know that there can be worry that screenings without a dedicated social worker to address barriers may create worry, but I can assure you that you can change that mindset in your organization. I tell my primary care providers to think of triaging social need just as you think about triaging other needs. I may not be a cardiologist, but I'm trained to recognize that you have a cardiac condition that needs a cardiologist. And in that same framework, we should be viewing social needs as important tools in really engaging our patients and helping them to reach their health outcomes. Next slide. In a short talk like this, I don't have time to highlight all of the work that we've done, but I wanted to give you a couple examples of some of the wonderful things from our team. We've partnered with Catholic Charities at My Brother's Keeper to provide primary care services and vaccination services. We've worked with several external partners for food access programs, including Hungry Harvest, Meals on Wheels, and Movable Feast. We've had on-site farmer markets pre-COVID, and we hope that there will come a time where we can do some of those sorts of programs again in a different setting. Not shown here, we've also done some partnership around violence prevention, which has been very valuable to our community and something that perhaps you wouldn't traditionally think of as a healthcare intervention in other places. It's also important to know that that engagement is not just with organizations, but with our frontline teams and really helping to empower them to bring things to the forefront. Our teams were really integral in talking about the need for transportation services beyond the existing contract we have with a ride sharing service. And we have a higher touch intervention that we call the Chaperone Program to help have someone accompany them on a transportation service for patients who really need that additional level of support. They also, we hold an innovation tank, and our teams have done some innovative work around diabetes, as well as a program called Care in the Gap that provided post-discharge home care services for personal care needs after discharge to help keep people out of from readmitting and support them in an independent environment when they left. So what this looks like in your office, your hospital, your large health system will look very different, but start somewhere. I encourage you to think about who those partners are in the community. There's a lot of wonderful work going on in our state. And so the great thing is we have many to choose from as partners and help leverage those. Next slide. So lastly, just to revisit those learning objectives, there are many barriers to this care. And we know that there are significant problems that we can't solve in a day. But remember, innovation really is our ally here in helping to bridge those gaps. Sometimes structural changes might be what you need to break down silos in your own institutions at a system level. So I encourage you to think about what those silos are and what the most effective way is to break them down. Also remember to navigate your navigators. Our teams need navigation too. And don't go it alone. Partner with your community-based organizations, your fellow health systems, and most importantly, your patients and caregivers, as well as your frontline staff. And with that, I will take any questions. Thank you.
Thank you so much. Those were such incredible presentations and such great information to share with our state healthcare community. So at this time, we can take a few questions in the chat function. People can also raise their hand. I believe you can do that in Zoom. Anana, do you see any questions that you'd like to read for us at this time?
I'm just looking through, Melanie.
I'm going to have a question for Siobhan. So Siobhan, if it is a small practice with small staff, how can the team-based care work for their practice?
So the first thing I would say is start the conversations early and look at the members of your team and collaborate with them together. In smaller practices, it's easy to determine the needs as you guys sit down and discuss and work together. And usually that's going to be led by the physician in the practice. When we're moving to wanting to see the change that we would like to implement, it's going to start with that physician to help support the needs of that group, sometimes an office manager, and be open to what your team has to give because they have valuable pieces of information to help structure and form your team-based care. And the smaller the team, sometimes the mightier. You're able to pivot and make changes pretty quickly. So really being able to adjust and work together on what you want to focus on. Team-based care does not have to be an all or nothing. So like, as I mentioned in the presentation, if you know that you're having struggles with your diabetic population, challenge that first and see what you can put together and organize together as a team-based approach for that population and that condition. That gives you all something to focus on together and you can see rewards quickly. And then you can continue to escalate to different populations as well as different factors of focus for your practice.
Oh, that is great. Thank you so much for that response. Dr. Kinder, I have a question for you. So how did you determine when to develop internal programs versus when to partner with an outside organization?
So I think this is something that hopefully you start with kind of a needs assessment of what you feel that your population needs. And then it's really, I think, a little bit of looking at the landscape around you. Sometimes when no one is doing the work, it's yet or working in that space, you know that it's something you need to develop. But there are many, many wonderful organizations out there already doing this work. And so I think the more that you can kind of see where people are. I think physical location is really important, right? So geographically, depending on where you are in the state, knowing who your partners are there. Being in Baltimore City, we have lots of large health systems to partner with, but it may look a little different if you're the only health system in an area. There may be more that you might feel that you need to take on or support because of those resources. So resource availability is probably the biggest piece.
Great, thank you so much. Anena, do you see any questions from the participants? Otherwise, I have a couple more.
I don't see questions at this time, Melanie.
Okay, so Siobhan, I have another question for you. So if the pilot team doesn't have the skills to create reports, how do they track progress?
So if the pilot team themselves don't have the skills to create the reporting that's necessary, usually I say when you're doing your organization and structures, the first thing you would want to do is tap into your IT team or your EMR services. Sometimes there's reports already available to you that can track, but we haven't turned them on. So if you physically can't create those yourself, then you may want to go back and work with your EHR to see if those specifically can be turned on so that you can kind of take a look at the data. And once you have access to the data, then you can really have a conversation. One, about what are we looking at? What are the goals that we need to move once we have access to the data, and go from there. For many of our Maryland providers, an easier way to even start and get information is by subscribing to your CRS portal that Chris offers you. If you cannot create any reporting yourself, that report does pull in information, and though it may not be all encompassing of your practice, it definitely has information usually for your Medicare-based population. And you can look at things like how quality is doing on those dashboards. You can also look at avoidable hospital tools. So patients that pretty much, if we had worked together in team-based approaches, we may have been able to avoid that unnecessary utilization event. And it also just gives you additional information. So Chris is something that we all have access to. So if we aren't able to create or start the reports ourselves, the biggest thing and the most important thing that I encourage any practice to do is access their Chris reporting tool, because that gets you started on looking at the technology and seeing where you want to go and what you can build in the future states.
Yeah, that is a great suggestion. Thank you so much for bringing that to everyone's attention. So I just have, I have one final question for Dr. Kinder. So what discipline serves as air traffic control, and how did you train this individual?
So we have actually had several different individuals in that role. So we have at times had a nurse, we've had a community health worker, and we've had social work. Currently, it's usually one of our nurses or social workers. We tend to find that, there's this balance of, right, sometimes if you give an algorithm that doesn't look enough at the individual case, then you kind of aren't funneling patients to the right resource. On the flip side, you could spend an hour chart review in every case as well. And so how do you find the in-between? So we have found that a lot of times for our kind of high risk, high complex hospital discharges, our nurse or social worker often is the resource. We have trained our community health workers in primary care, however, to do this. Again, we don't always have a nurse or a social worker at every practice at all times. And so I think it's really about first making that decision tree, and then kind of having a few prompts that say, okay, if this, we need to be concerned about maybe this isn't the right resource, or level that up to the provider or something to say, hey, I have more questions about this particular case. But there isn't an easy job description for that role, unfortunately.
I think that's some great guidance and a really innovative, interesting model that you guys are implementing inside your system. So I want to thank all the presenters today for some really great information that they provided to everyone. I want to thank all of our attendees. If anyone is interested in getting continuing education credits, please be sure that you fill out the CME survey that goes to MedChi. Again, thanks to MedChi for supporting this. So if anyone does have questions, they're welcome to email me after the fact. The slide and recording will be posted online. And again, I just want to thank everyone and wish them a happy holidays. Bye. Thanks.
Bye, everyone. Thank you.